If we can get settled in, we'll get underway. I'd like to welcome you back after the lunch hour. We have some very stimulating speakers for the after lunch hour period so that there'll be no napping. We're going to be making the case for interprofessional clinical practice and speaking about innovative oral health models for healthcare delivery systems. The moderator for this session will be the President and CEO of the American Dental Education Association, Rick Valachovic, and he has been a steadfast advocate for this as long as I've actually known him. He's been speaking in these terms, and we discovered that it was 20 years now. So, you know, he's an early proponent of changing the model of practice and teaching in dental education, and it's a great honor to have him here to moderate this session. Thank you.
Thanks, Mark. So, good afternoon, everyone, and I hope that we can indeed keep you awake in this post-perennial moment. My day job is indeed being the president and CEO of the American Dental Education Association, but I'm also serving now as the president of the Interprofessional Education Collaborative. As Charles Bertolami said this morning, IPE and collaborative care has come and gone as a fad over the last 40 or 50 years, and there has been a lot of interest in it. There's been research in it. There's been a variety of different meetings, but there never was really any impact, any real movement until relatively recently. And so why now? Well, there's some things I think that happened very specifically in the year 2012 that made things very different. In 2012, the majority of physicians became employees. In fact, in Minnesota, almost 75% of physicians are employees. So when physicians become employees, it doesn't mean necessarily that they're going to be told how to practice, but the way that patients flow through the system of that health system are going to change. And there are financial imperatives that say these patients are going to go to the physician, these patients are going to go to nurse practitioners or PAs, pharmacists, or whatever. The second thing, of course, is that the majority of babies in the United States that were born in 2012 were not white. So there's a demographic change that's going to be occurring, and that's going to impact things. And the third thing that happened in 2012 was that the Affordable Care Act was upheld by the Supreme Court. So what we've got is market forces changing on the health system side and market forces changing on the government spending side. And as we learned this morning, currently more than 50% of healthcare spending comes from the government. And as we look to what will roll out over the next few years in terms of the ACA and moving from volume to value and payment systems that are going to change, these are finally the market forces that are going to make things different. So the systems change underway. So in around 2008, a group of us in Washington, D.C., came together to try to anticipate what this was going to mean for our schools and programs. So the CEOs, like myself, in Association of American Medical Colleges, Association of Colleges of Osteopathic Medicine, Association of College of Pharmacy, Association of Colleges of Nursing, and the Association then of Schools of Public Health came together to try to anticipate what was going to be happening and try to begin the process of educating to a new way of thinking in a collaborative way. Since 2008, we have met by phone every Monday morning at 8 o'clock, with the exception of those holidays, and we've met for a full day 4 times a year. We came together and from the start agreed that we would be in a demilitarized zone. We would not speak scope of practice. And that has sustained us throughout, I think, all of our time. We've been respectful of that. We came together to promote a common language and competencies. In 2009, we published the core competencies for interprofessional collaboration and practice, and I think that you know that has become a standard in our world in terms of competencies towards the future. We had a commitment to faculty development and teaching in an interprofessional way. We've held now 10 faculty development institutes, 300 teams from different academic health centers have come together, 1,300 individuals over the past few years. Creating shared learning resources with a grant from the Macy Foundation. Through the MedEd portal, we've created a resource center for materials on interprofessional education and collaborative practice, as well as a variety of other things that other resources that we've created. Trying to identify best practices. I think that you know that interprofessional education is highly variable in different institutions. Some is from the top down. The chancellor says, next year, we're all going to start on August 1st. All lectures are going to be 90 minutes. All clerkships are going to be 6 weeks. And at other places, it's 2 schools coming together, like dentistry and nursing. At other places, it's students getting together and saying, we're going to create an IPE approach from the bottom up. And that has worked well. We have always wanted to advance the science and practice of assessment. We need to get that going. We have to develop that. But certainly promoting interprofessional collaboration with policymakers. We have met with everybody in Washington, D.C., CMS, White House, HRSA, VA, NIH, and all of us are members of the IOM Global Forum on Innovations in Health Professions Education. Accreditation, whether you consider it a carrot or a stick, is part of it. As we talked about pharmacy this morning, pharmacy probably has the most heavy-handed standards around interprofessional education. The other 6 of us are less heavy-handed, but now we've created a consortium of accreditors who get together how can they help each other create interprofessional opportunities for education. We expanded last year. From the 6 of us, we added 9 more organizations, psychology, optometry, physician assistants, social work, occupational therapy, physical therapy, veterinary medicine, podiatry, and allied health. And so we now represent hundreds of schools and programs, tens of thousands of students and residents. But like you heard today, our success has been frustrated by the slow rate of change on the practice side. We had one session that I was at an academic health center in the Midwest. The students who were there said, "You are all hypocrites. You teach us in a interprofessional way, and then you send us out into clinical environments that haven't changed since the 1950s." Kaiser Permanente has tried to get a variety of different opportunities for medical students who are going to come into the Kaiser system in different medical schools. They couldn't make it work. They finally decided, fine, we're just going to start our own medical school. And they're on the way to making that happen. That the investment in that was more worthwhile than trying to just buy 60 slots in another established medical school. So let me finish with a quick story. The 6 of us in the IPEC were invited to a White House meeting about IPE and collaborative care. In the room were 45 people. Presidents of universities, presidents of specialty organizations, the head of the VA health system, so on and so forth. The secretary says, okay, we're going to go around the room. I want you to say who you are, where you're from, and why you're here. So we go around the room, and I'm thinking, what am I going to say? Why is dentistry here? Fortunately, I had a few minutes because they went around the room, and I'm sitting here, and I had a chance, and I came out with, I'm Rick Valachovic from the American Dental Education Association, and you're wondering why dentistry is at this table. And almost universally, there sort of was an acceptance or a sort of the squinched face kind of thing, you know? And I said, here's why. We have 500 million patient encounters a year. We see patients when they're healthy for the most part, not when they're sick. As was mentioned this morning by Bruce, the majority of draft deferments and deployment refusals from the Civil War through Iraq and Afghanistan were because of dental status. We have a history of prevention. We have a history of interprofessional practice with dentists, dental hygienists, dental assistants. Who more than your dental hygienist makes you more guilty about your health habits? And obviously the oral systemic connection and infection is infection. And for the rest of the day, about once an hour, there was, why can't we be more like dentistry? So today we're going to hear about integration and collaboration of dental and healthcare. And I think we've got a group of people who are making things happen. And so let's hear about what it is that's happening. First up is David Gesko, who's the Senior Vice President and Dental Director at Health Partners, and he's going to be talking about the work that they're doing within their health system. David.
Well, I'd like to stand down here and just kind of watching for any head nodding after lunch, and I'll be the monitor for that. So it's great to be in New York, and as you know, we're all held to this 12 minutes here, and so being in New York, I've been reading the papers and listening to the news. So I thought, how do I get around that 12 minutes so I can talk longer? And so I made a contribution to the New York University Foundation, and I'm told that I get 15 now. So anyway, I'm from Minnesota, and some of you might be able to pick that up in my voice, possibly. I've heard that a few times. And what do you think of when you think about Minnesota? Minnesota nice? We talked about that earlier. So how many of you know what we're looking at here on this slide? There's a couple of you from Minnesota that can't answer this question. All right, do you see what we're looking at here? Snow, obviously, but what is that blue tip? Periscope. Periscope. No. Newcomers to Minnesota, many times, and if they come during the summer, they ask, why do the fire hydrants have these poles on them like that? And then a few months later, we don't have to answer those questions. So anyway, it's good to be in New York. We want to talk about a healthcare system in the Midwest where integration really is the norm. And so as we struggle with that issue here at this conference, we're certainly not the gold standard, but we try very hard at integrating care across our continuum. I'm happy to talk to you about that. The foundation for all of this is the triple aim. And so I know all of the people in this room are very fluent with the triple aim, so we'll be talking about that as well. We want to define dentistry's role in the larger healthcare model, and then identify just a ton of opportunities where we haven't integrated, where we can do so in the future. So this is us. This is Health Partners. A busy slide, yes, so let's just focus in on the dental component there for a moment. And we've got 75 dentists, 60 hygienists, and yes, who wants to speak that next 3 dental therapists, which I don't think anyone else in the room can claim that. So we're proud of the fact that we're the first state to legislate dental therapy, education, and licensure, and we were happy to employ several when we first could do so in 2011, and it's been going great. And hopefully in the future at IPE conferences like that, we'll have dental therapists represented as well. But as well, you can see that we have some 1,500, 1,700 physicians, 6 hospitals, and so we're a very robust healthcare system in the Twin Cities and up through central Minnesota as well. Everything is about the triple aim. If anyone said, well, what is the key to your success or the key to your model at Health Partners, it's clearly the triple aim. It's not just a medical formula. It's one that we all embrace. And we really enjoy being able to filter everything that we do through the simultaneous goals of the triple aim. So there we are. We really are in a position where we can't lose because all of us is created under this one umbrella, and we've got hospitals, medical group, dental group, our dental plan, our medical plans, our research. We're all there, and so it's really the formula for success. Those components of the triple aim that really drive to the success, I really want to say that the most important thing on this slide is our culture. Because cultures make or break organizations, and if you have a culture that really strives towards working together and partnering, which ours does, it really does give us the opportunity to deal on this integrated system that we're talking about. So we live in a life of change. Some of you will recognize if you've been to Minneapolis that this was our Metrodome. And it was built while I was going to dental school there, and we watched this being built. And I came back to Minnesota after being gone for some 20-some years, and they were talking about how the Metrodome was just a has-been sports arena and way over its time and definitely needs to just be torn down. And I was hoping that the lifetime for stadiums was much shorter than for dentists as we were watching this being built, and hopefully that's the case. But indeed, it was torn down, and now Sunday is the first regular game for the Minnesota Vikings against none other than the Green Bay Packers on Sunday. And I looked earlier today on SeatGeek, and you can still get good seats for $2,000 a seat if you're interested in going. So it's amazing what you can get when you spend $1 billion. Well, how many of you remember this? Remember how impressive it was to carry one of those around? I mean, everyone knew you were important because you had this huge phone with you like that. And so everything changes, and now our phones are very discreet and tuck away easily. Dentistry is changing too. I won't ask if anyone is familiar with this, but now dentistry is very high tech. Everything is done with lasers and through microscopes and so on, and dentistry has changed a whole lot too. Quality has changed as well. From what dental school taught us in terms of 3-point contacts and so on, in terms of now, it's all about population health, reduced risk, greater value, cost effectiveness, which we really think is the triple aim. And so striving towards the triple aim is the right map. Our dental group has these following practice principles that I'd love to talk to you about in depth, but I'm going to just skim through them very quickly today. Evidence-based care. What is evidence-based? It's really taking everything that's out there and distilling it into what we call care guidelines. And those care guidelines then aren't just sitting on a shelf collecting dust, but they're right incorporated into our clinical practice and into the compensation structure of our dentists as well. If you go out to guidelines.gov and type in dental guidelines or type in health partners, you will get all of our clinical guidelines, and we're proud of that, and we're proud that we go through the time to work those up and post those in that spot. Here's a really great example of the intercollaboration that we've done. Our physicians had struggled with how to get their new physicians and residents to be able to optimally treat patients with diabetes. So we took that concept and we did the same thing and created an internet-based system that allows our dentists to be able to practice in a more evidence-based manner. All of our patients get risk assessments, and those risk assessments are for decay, for gum disease, and for oral cancer. They all leave with advice on how to mitigate their risks, And then also they all get a blood pressure too, which we use as low-hanging fruit for collaboration. Many times we find patients with blood pressures that are out of line and we refer them into the medical system, only to have those patients sometimes come back and thank us for being able to direct us to the right places. So we preserve hard and soft tissue. We use that medical model. We have diagnostic codes in our vernaculum, and we have for 15 years. Got a rich data of diagnostic codes, and we're excited now. You'll see some screenshots of how those diagnostic codes work. One of the things that we're excited about next year is we're going to be moving to the Epic medical record, which all of our hospital and medical system is on. So we feel in terms of collaboration that that's going to be the biggest link right there to help us work together more effectively. But in the meantime, we've created a link on our dental record that when you click on that, it takes you to a web page that pulls data from our medical record and displays a patient's medical conditions, their medication list, and lab values that they've had done recently. And as a provider of care in our system, this is just a fantastic way to be able to know that patient better and to work more successfully when you do have that up-to-date medical history. Another collaborative issue that we've had is that we've recognized that there's growing evidence for patients that have diabetes that have optimal periodontal care. So we wanted to reduce the barriers. Other carriers have done this as well, I believe. But so if you're pregnant or if you have diabetes, we waive all copays, no annual maxes. We make sure that the patient gets the perio coverage they need. We've also done a pilot where we've used our disease management nurse system to reach out into populations of known diabetic patients where through claims history they haven't had any periodontal care. And we encourage them to get into the dentist. We help them get into the dentist so that they get that care that they need. All right, and then we're stratifying those into low and high risk and then appropriately kind of channeling them to the care that they need. We've done some great tests and pilots, research projects through our practice-based research network. This is one I participated in where we did blood glucose testing. And we found that because there's an epidemic of diabetes, we screened our patients, our dental patients, for diabetes, and when they answered these questions, we did a finger prick, and we took that, and then we referred them appropriately into the care system. So we didn't make any diagnosis, but we screened things, and we really got them to the places that they need. The aim of the study was to say, is it feasible in the dental office to do these things? And the answer came back absolutely yes. And this is the kind of reports that we got from the dentist, that they did not feel disrupted by this, and it was actually fun to have a little bit of change in your practice and interact with your patients in a different way. All right, you've seen some of these slides possibly from the ADA Health Policy Institute. If we were to be able to do screenings like this, we see 27 million people that don't see the healthcare system or the physician system. So we've got a great population to work from. The savings would be incredible if we could really get this down. And the last part of the triple aim, of course, is cost of care. And we've measured cost of care throughout our whole life cycle. Cost of care is much different than just what's your discount. That's so frustrating to me in our plan world. And we really find that our cost of care, our total cost, which is not to be confused with discount, is 26% lower than the traditional fee-for-service dentist. So these are the elements of the triple aim that we're focusing on in terms of making healthcare more affordable as well. And lastly, experience. We blow up those questions. We ask patients about the thoroughness of the treatment, the attention, explanation of what was done, and these are important elements as well of that. Where do we go next? Conferences like this help us focus on the things that really are important to drive to achieve the results that we're looking for. Diagnostic codes, quality metrics, risk assessment, performance measurement, reimbursement of our reimbursement system must be evolved. It's terribly broken, in my opinion. And of course, dental research to help us prove this. So thank you very much, and we'll have questions at the end.
Thanks, David. So next up is Jeff Hummel, who's Medical Director for Healthcare Informatics at Qualys Health in Seattle.
Thank you very much. It's a pleasure to be here today and participate in this. I'd like to tell you a little bit to start. First of all, we're going to take a break from PowerPoint for just a moment. As you know, power corrupts and PowerPoint corrupts absolutely. And I think just a short break, and I'm going to kind of set up the slides I do have by telling you, first of all, about Qualys Health, which is a not-for-profit national consulting group with a background as a quality improvement organization since the mid-1970s. So we do a lot of Medicare work in quality improvement. We also were the Regional Extension Center for Washington and Idaho. So Qualys Health really, to me, brings together, in a way that was discussed this morning, the knowledge domains of clinical care, quality improvement, and health IT. And we apply those mostly to small practices, to rural practices, to underserved communities, community health centers, and the like. We are a newcomer to oral health, and in total respect to the people who have been doing this for decades, and I really want to take my hat off to you. The work that we've been doing over the past couple of years is really built on and should in no way eclipse the tremendous contribution that people in this room have made. We are newcomers, but the reason that we were asked to participate from the NIIOH, and I believe it was in 2014, was that what we have been doing for decades is population health, practice transformation, primarily on the medical home model, and care integration with domains like behavioral health and substance use, pharmacy, ophthalmology, eye care, foot care, things like this. So the things that have been carved out of primary care. So when we started to look at oral health through this lens of care integration and population health, a couple of things became really clear. One thing that's clear is that the current model for providing oral health in this country isn't working the way it's set up, and it needs to change. And so what we approached it from the perspective of is primary care. That's what we know, and that's what we're going to talk about today. And what became really clear to us was that we needed a conceptual framework for oral health integration that was intuitively obvious to primary care providers. We also needed a map or a guide for implementing oral health into primary care, so that groups that were starting out, where that David was talking about, his was clearly down this road, but others following that wouldn't have to repeat and learn things again. And then we needed a whole array of tools to do this work. So we published a white paper in 2015 that basically summarized the case for change and laid out a conceptual framework. And simultaneously, we started the Oral Health Integration Project that involved 19 practices in 5 states. And this covered, in primary care, the gamut of fee-for-service practices, community health centers, urban, rural, small primary care standalone groups, and then ones that were part of integrated delivery systems. We had 5 different EHRs, a lot of which the names you'd recognize. We provided technical assistance ourselves to some of these practices. We did it for the majority of them through the primary care associations in their respective states. And what we were able to show was that that across the board for all these clinics, they were able to implement a system-wide change to greater or lesser degrees by, number one, defining the population that they wanted to impact, 2, defining an oral health standard of care that primary care would be involved in, and then establishing a workflow in a pilot and then spreading it to the rest of the organization, and then being able to measure what they were doing in terms of process. The implementation guide and the tool set that have come out of this will be published later this month. And so what I'm going to do with the remaining time is show you just a handful of the tools that we're going to be publishing. I want to tell you, if they seem simple, it's because they are. This is very operational work. It's on the front lines. And primary care teams are functioning in a world that's very complex, it's very fast moving, and it's confounded by fragmented information. And so what they need is for us to simplify, simplify, simplify. So it's hard for them to change unless what they've done is settle into patterns of practice just to survive, just to get through their day. And if we want them to change, we have to make it easier for them to do what they're trying to do. So the examples of the tools that I've chosen to show you, well, before we go there, when we started this project, we interviewed national experts like yourselves and to find out what will it take to change the standard of care. And we got a lot of interesting answers, but they fell into three categories. One is it's going to require a clear definition of what can be done in primary care. What should it look like? We need a streamlined way of fitting that into the primary care workflow, and then we needed a good model for collaboration with our dental colleagues. So the framework that we settled on, we call it the Oral Health Delivery Framework, and it's modeled basically after subjective, objective assessment plan. So primary care people will recognize it. You ask a bunch of questions, not very many because they don't have time. You look for very specific things. Primarily what we're looking for is signs of disease. What you're asking about and also looking for is modifiable risk factors, something that can be changed by behavior or coaching or something like that. And then decide, is this normal or is there something that we can intervene on, and what's the action? And of course, we need to document. It turns out that there's a very limited number of things that we're asking primary care practices to do. We're asking them to basically look for two chronic infections, periodontal disease and caries. We're asking them to assess a limited number of modifiable risk factors. And then the interventions they can take fall into the categories of either applying fluoride therapy, usually it's fluoride varnish, coaching on some level, maybe changing the med list based on, so that requires a clinical judgment, and then referral. So it's pretty simple. The question is, who's going to do that? And it really depends on the practice. But what we did, as we talked about this morning, this is not something that a primary care provider can do by herself. It has to be done in a team. So what this slide shows is a protocol-driven approach to delegating clinical decision-making. That doesn't mean the provider's not involved in this. They have to oversee it. But we have to provide ways of the medical assistants recognizing things, saying, I think this is going on, and setting up orders for stuff to happen. So over on the right-hand side, you'll see the interventions that a primary care team can make. Fluoride varnish, medical therapy, by which I mean changing the med list. It might be in response to oral dryness or acid reflux. There's the coaching, and then there's the referral to dentistry. The clinical conditions we're asking them to look for are down the middle, and then which ones those link to are color-coded there. And I'm not going to go through each of them because of the time here. And then we've given an informational or data definition, if you will, a criterion for each of those conditions. And it's a one-to-one thing. So if we say that we expect people to brush their teeth twice a day for 2 minutes using fluoride toothpaste and floss once a day, if they're doing that less than half the time, that constitutes oral hygiene risk, and you follow that out. They get fluoride varnish. And it looks like on this they also get the coaching. So we set this up. This is not set in stone. It can be changed any time that we get new evidence. So let's move through this. This is a kind of a standard workflow that I'm actually going to skip over to show you some tools that we developed for helping care teams figure out where in their practice they're going to put each of these things. So this is kind of a standard workflow. Patient schedules the visit, the front desk prepares, the back office or the clinical team prepares and for the visit, then the patient checks in, and then the patient gets roomed. So what we do is we go through with the team and show them what they're already doing. And this shows you how busy these teams are. This is sort of a standard list of things that commonly get done during a visit. So cramming a few more oral health things into their workflow is not something that just comes easy. But what we do to help them with that is we have a list. This is an interactive slide. If you take it out of projection mode, you can actually grab those little lines and pull them over towards the stage in the workflow in which you want it to happen, or you can delete them altogether if the team says, no, we don't want to do that. So this is all done with the team creating their own future state workflow, and what you end up with is this. So the care team says, we are going to identify the people who need to be screened, and it's going to be the care team that does that. Here's who's going to ask the questions. Here's who's going to look. We're going to give the medical assistants the opportunity to set up orders, and on and on. So this is how we do workflow. We can get this done in usually a couple of one-hour sessions now. We've gotten it really efficient because the care teams have no more time than that. Let's switch gears for a moment. If we're going to develop a practical model for close collaboration between medicine and dentistry, which is that third question, I felt like we just scratched the surface of this. There's really 3 different models that we, at least, were exposed to. 2 predominantly. One is where the practice has to go out and find dentists in their community and establish a relationship with them. And that's very dependent upon the personalities of both the primary care people and the dentists. We found some great successes. We found places in the community healthcare system, in the community clinics, I should say, in which they had on-staff dentists and were actually they were able to see more patients and not lose money doing that, and we could actually refer there. Many dentists are willing to take referrals. It's a very different dynamic in the co-located practice, and what we did develop for working together there was a set of information needs on both sides. And then there's this integrated team vision for the future that the Harvard folks are working on, which is really exciting. So this is just an example of the type of workflow that we help practices understand the need for setting up formal referrals. And the title of this slide should actually be the information needs. So when the medical referral is sent to dental, there's a clear request for the service that's required and the reason for the referral in addition to the relevant clinical information. And then when the dentist sends the referral consultation note back, it has the date the patient was seen, what was found, what the disposition was, and what the follow-up plan is. So I'd like to close with talking very briefly about reporting, because a lot of the tools that we developed were based on the information flow. I'm not going to spend any time complaining about electronic health records. We know what the issues are. But the point is that if we're going to think about population health, we need to have a very clear way of understanding how we display information for that. And we found that the practices were not prepared to do that. If we asked them to do reports on how many on the percentage of their population that they'd screened in the last year, say for diabetes, what they gave us just intuitively was a number of patients each month that they screened, which is a very different report. It tells you where your unit of analysis is something the provider team did. What we want is the patient. So we came up with this mantra that helped the primary care teams understand what we were asking them to do. Who's in the target population? We want a list of their names. And it's on today's date, the reports run. Who have we screened in the past year, if that's your criterion? What did we find? And what did we do based on that algorithm? So it looks like this visually, where you have the target population is in blue, the people who've been assessed within the specified time period is red, and what the difference between that is a care gap. And then, depending on what you found, did they receive the corresponding intervention? And that's a care gap. And we focus on those. And what we give them then is over a year, with a 12-month look back, you can start to see what percentage of the population in this case has actually been screened. So I'm going to end by just showing you, this is basically what our future tools, the implementation guide that, as I said, will be coming out later this month, will look like, and what the content will be. This, like many aspects of this work, was funded by DentaQuest. We included the Reach Foundation in Kansas City because they played a major role, as well, of course, NIIOH and the Washington Dental Service Foundation. Thank you.
All right, thanks. Thanks, Jeff. Next is Amir Morsi, who's chair of the Department of Pediatric Dentistry here at NYU College of Dentistry.
Good afternoon. I want to first start by thanking Judy and Dan for inviting me here to share some of our work. We in Department of Pediatric Dentistry have been really fortunate. We were one of the really early partners with Judy and her team on ONEP, and Aaron described some of the collaborations we've had, whether it was with our IPE clerkship at Bellevue Hospital, where a medical student, dental student, nurse practitioner student are together, being precepted by a pediatric dental resident, or having our nurse practitioner student come out with us into the community, into the Head Start sites we go to. It's been a wonderful partnership. We've also, for many years, had nutritionists in our clinic. We have nutritionists virtually every day sitting chairside doing dietary analysis and nutritional counseling alongside our dentists. And that's valuable time. So when that child's being treated or getting a checkup, instead of having mom play a game on their iPhone, let's use that time. Instead of just sitting in the waiting room, let's talk to a nutritionist, for instance. Those kind of team approaches are that we've heard a lot about already today, I think are critical, and are some examples of this interprofessional practice that we're talking about. We're very integrated also into the craniofacial team we have here. In my previous life, I was a craniofacial bone biologist, largely inspired by Dr. Slavskin's work, and that's a team approach. So we also are very involved in the pediatric oncology center. So Erin Hartnett was the champion in her previous life as a pediatric oncology nurse. We're there every day, and it's a two-way street. It's not just we're showing up to do a dental consult, but medicine is contributing. I think those are all good examples. Yes, those are students who are involved in their trainees, residents, so it's interprofessional education, but those are clear examples of interprofessional practice, which then can be extended. And I'll talk today about another project we're involved in that's really putting that to the test out in the community. First, a little background. So, oral health in the child in particular is a huge public health problem. I won't go through all these bullet points. You can read them. But you can see the impact it has across the population and how common it is and how many children it's affected. And this is at the population level, but it can be particularly tragic at the individual level. This April, it was kind of mid-April. It was a beautiful spring day, one of those first warm spring days. I was having my morning coffee, checking my email, and I get an alert about a child who had died in a dental office in Texas. Tragedy, these happen periodically, and it's one of those things that just catch you. Certainly as a pediatric dentist and also as a parent, it's tough. Within a few minutes, I got a phone call, and it was a producer from CNN, gotten in touch with me through the American Academy of Pediatric Dentistry, and wanted to know if I was available to speak that afternoon live on CNN about this tragic death. So, got myself down to Time Warner Center, and they put me in this tiny little room where there's no one else, and there's this automated camera run by someone down in Atlanta. And time comes on, a reporter comes on. Hello, Dr. Morsi. Why was a 14-month-old being treated under general anesthesia for cavities? So how do you answer that? So that's we hear the population numbers, but that's at the individual level. Luckily, that's rare, but that's the consequences we're talking about. It's not just a cavity. As you can see here, it affects the entire child across the lifespan as well. So there's a lot of data showing this affects you not just as a child, but as an adolescent, as an adult, and not just dentally. And it's a chronic pain. And those of you who kind of study pain know this. There's a difference between acute pain and chronic pain. Many of the children who have severe oral disease don't complain about pain. They don't say, "Mommy, it hurts." They don't wake up in the middle of the night screaming. but it's a chronic low-level pain. Kind of like, you put your glasses on in the morning, you kind of feel them right when you put them on. The rest of the day, you don't notice they're there, but they're there, and they're having some effect, usually a good effect. But with the chronic pain these children have orally, it is expressed in other ways. So, and the most dramatic example of this is when we'll have a child who's had very severe decay for years, and we'll treat them in the operating room. This just happened last week. I usually check in the next day, hey, how's little Susie doing? And mom says to me, what have you done to my daughter? You never want to hear that, right? Like, uh-oh, what happened? Her daughter, who was irritable, cranky, picky eater, didn't sleep well, was suddenly this pleasant child, happy, smiling, eating everything in sight. And that's not because I'm some miracle worker. It's because she had clearly been in chronic pain for years, and now we had alleviated that. So this is kind of how it affects a child, and you can see obviously how that would affect one's ability to sleep and socialize and do well in school. What we also know is that most of this problem is concentrated in a very small minority of children. And who are those children? The low-income children, the children of immigrants, the children of family of color, children of parents with lower education. So we know that population. The way we currently manage early childhood caries, ECC, is not terribly effective. And you can see kind of all the problems with that. The recurrence rate on these children that we end up taking to the OR, and I shouldn't say not everyone ends up in the OR, but most children, many children under the age of 3 who have severe decay do end up either needing sedation or treatment under the operating room, and you can see the recurrence rate there. Now, yes, we're all about prevention, and this is at its base a preventable bacterial infection. So we try to prevent it using some of these modalities, whether it's toothbrushing and fluoride, but it's not effective. All the studies show that really the way we're doing it in a model where it's a dental setting, and frankly, even in a primary care setting, if it's a nurse practitioner or a pediatrician, we're giving them information, we're giving them the kind of good pat on the back, and then sending them out. There are other models. So asthma, if you think about it, it's similar in some ways. So it's kind of a chronic disease. There's acute exasperations. There have been some wonderful ways to address that. And so this group, some of you may know this work up in Washington Heights, it's here in New York City, took this population, very high rate of asthma, very uncontrolled, and sent community health workers out into the field and really focused on just a couple things. One is triggers. If you know about asthma, most of these asthmatic attacks have triggers, either dust or some smoking in the home, that sort of thing. They try to reduce the triggers and increase compliance with medication. And not just those rescue inhalers, the chronic continuous medication that's meant to reduce these. Huge effects. You can see they reduced hospitalization, which is a huge cost, huge stress. Can we use that model for caries management approach and create something that's targeted, highly customized, goal-oriented, and goals that are customized by the family? So that was the goal of this quality improvement demonstration project. This is a project, the overall PI is Dr. Bert Edelstein, who many of you know up at Columbia. I was the PI for the NYU subaward. We were in charge of the clinical side of this, coordinating 5 clinical centers around New York City for recruitment and the clinical data outcome measurements. So the idea was, if we can identify children who have early childhood caries, which we do when they come in to see the dentist, then maybe there's a way to reduce the number of these kids that end up in the operating room with this high cost, high stress, not very successful treatment approach. And we aim to follow kind of this asthma model. Train community health workers to go and visit the home and now augment and support in a customized way all that prevention information that we gave them about diet and fluoride and oral hygiene and follow-up visits, that sort of thing. And this would be over a 12-month period. They'd make up to monthly visits. They'd have phone calls, texting. We used a stannous fluoride gel. What's nice about the stannous fluoride, this is for the dental geeks out there, it has a very high amount of fluoride in it, more than just kind of your standard Crest or Colgate, but still low enough that it can be obtained without a prescription. So little things like that made this possible to give us all the tools we could possibly get. Here's the outcome measures. We had a number of kind of the standard oral health clinical outcome measures, number of behavioral measurements. When they would sit down with the parent, they would go over goal. Okay, what's the goal for this month? Okay, the goal is I'm going to try to have my child go to bed without Pepsi in the milk bottle. Okay, that's the goal. We're not going to worry about toothbrushing. We're not going to worry about, that's the goal. I, as a mom, I think I can do that. And then we measure that and see how well they achieve those goals. We also looked at the economics. CMS funded this. They're interested in the triple aim, and one of those aims, as we just heard, is cost. Would it be worth it to spend that upfront cost to pay, to reimburse for community health worker home visitations, care management, case management, sorry, would it be worth it? Would that save money on the other end? And that's one of our goals. So we're crunching those numbers, working with a health economist to see if that, in fact, is the case, to give support for now starting to reimburse for that case management fee, similar to what we have in medicine. This has been going on for medicine for quite a while. One of the hopes is we could now provide a body of evidence to support this use in dentistry. So it's a 12-month follow-up. We're just coming up to that 12 months, so I don't have any hard data for you. Hopefully, we'll have some soon. But we have learned some things. We've learned that despite this being free, despite it being addressing a need, their dentist just told them, your kid has cavities, parents are still very reluctant. Just because we think it's a problem doesn't mean the family thinks it's a problem. And they'll tell this community health workers, you know, what I'm really concerned about is job security. Am I going to have a job? Housing. Am I going to be able to stay in my apartment? You know, it's easy to tell a mother, hey, stop putting your child to bed with Pepsi in the bottle. But when she tells you, well, you know what, we rent one room in this 5-bedroom apartment, and it's a single mom with 3 kids, and you know, if she cries in the middle of the night, they're going to kick us out. They've already told us that's a problem. I got to give her the bottle. That's the only thing that keeps her from crying. So these are the kind of issues the community health worker works with. Food security is another huge issue these families have. So when you come by and now say, okay, you know, we want you to brush your teeth twice a day. So, but that is what then they start using some of their training for, their motivational interviewing techniques, addressing some of those. Okay, let's address those issues, and then we'll get to oral health. Okay, what can I help you with your housing, with your food security? There's still a culture of deference, especially in a lot of the immigrant populations we work with. The doctor is the doctor, and I'll just nod and say agree, but I don't want to defy that doctor in place. So, but it doesn't really transfer at home. And they've learned to have to be creative. Maybe, you know, coming to the house is not the way. Maybe I need to meet them at school when she picks up her kids. Maybe I can meet a group of parents in the local bodega or cafe. Maybe texting or email is the better way to go. Is there a way to do this in a different way? Dental clinics is another. So actually integrating, having the community health worker in the clinic. So I'm going to wrap up there. This is a wonderful project. We're thrilled to have, hopefully we'll have our data out soon, and we can use this as another great example of interprofessional practice. Thank you.
of strategy and platform development, surgical services for Pacific Dental Services.
Thank you. Good afternoon. My slides up here. So I don't know if you guys noticed, but I'm the only person on this panel, or actually at this meeting, that's not a doctor, I think, right? I didn't even stay at a Holiday Inn last night. So I feel a little intimidated here.
You'll be fine.
All right. So Pacific Dental Services, we're a DSO, for those that don't know what that is, dental service organization. So we do all the business services and support for dental practices. We have about 550 of them across the United States, 85 pediatric practices. We're primarily in the West, and then we sweep down across the Southwest, and then we're moving to Virginia soon. So we've got about 10,000 employees, and so we're one of the larger groups in the dental space. So that's who we are. We also have a foundation that does charity work domestically, internationally, and we also do policy work. So what I'm talking about today real quickly is a commercial approach. So unlike a lot of the things you've talked about, or a lot of the ways that dental and medicine have been integrated in the past, most of those applications have been in the public sector, university settings. This is a commercial approach. And what our hypothesis is can we make this work, in a commercial way? Because if you can't, it's going to be really difficult to have this ever become a reality, right? Because most of we have a lot of academics here, a lot of your students, most of them go to work for folks like us. They go to work with us. So they have to make a living at it. So I'm going to burn through these relatively quick. You guys all know this stuff, but if you want to use the slides to educate anybody else, that's what they're here for. So I'm kind of moving from the volume to value, bending the cost curve down, especially on these difficult cases. What's the main underlying condition? This is a slide we use for our patients. Really it's all about inflammation at the end of the day. So how do you get that inflammation under control? And the main oral disease, obviously, is periodontal disease. And then again, this is the treatment for it. You guys know this. So we'll get to the main part of this. So this is our clinic. It's our first medical clinic that we are supporting. It's in Summerlin, Nevada, which is outside of Las Vegas. It's in a middle to upper middle income market. You can see there's the office building there. The new team there, Dr. Waltman and the MAs. Kind of a little bit look at the environment we're going after there. And so what are we doing in this? So the structure is, it's a medical PC and a dental PC, and these offices are actually combined. So if I went back, that's Canyon Point Healthcare. Canyon Point Dental is right next door, and they can join in the back. So the patients can actually go from one side of the clinic to the other. But the way it's structured is we're a PC for both the MD and the DDS, but the physical plant's co-located. Each practice has their own patient database record, and but we have separate EMRs because, as you know, there's no collaborative EMR yet. So we've used NextGen for the outpatient clinic, and we use QSI for the dental side. Naming convention's the same, so it's Canyon Point Dental and Canyon Point Healthcare. We are using the term healthcare right now. We're kind of testing out. This is an experiment, so we're testing out what's going to work best for the public. We co-brand on the websites. We are PPO and self-pay right now. So in our dental practices, we don't take any governmental plans. So right now we're at the same modality with our medical practice. We may take Medicare at some point. We're credentialed and set up to take Medicare if we need to. The teams huddle every morning together. They go over the schedules for both sides of the businesses, talk about the patients that are coming in so we can collaborate that way, talk about any issues we're having. So we've been open 10 weeks, so this is all relatively new. Clinicians leading clinicians. So one of the things we're doing structurally from the education side, the dental side, we've massively beefed up the health history. So all the dentists that work in Canyon Point Dental go through a much deeper health history than other practices do. Talk a lot about systems review. They do a much deeper medication review, and they do even a basic review of systems. So we do blood pressures and those types of things. In the future, we'd like to add point-of-care testing. This is an issue with credentialing and with state regulations. So we'd like to see that expand for dentists to do more of that type of point-of-care testing. The medical side, there again, same thing. Dr. Waltman does a full oral exam, gums, hard tissue, lips. We do. Are you bleeding upon brushing? A lot of deep questions about oral health. And then if he identifies, he pulls the tongue out, looks underneath it, the whole thing. So it's a full exam. That's also notated on the chart as well. And then the staff is cross-trained in each other's profession. So we have the dental assistants and the medical assistants kind of cross-trained. So strategy is adolescent and adult care. There again, I said upper middle income. You can read those things. We're really trying to intervene before they get the disease. So we're trying to get people at 35, 45 years old and catch them before they have these diseases develop. So pre-diabetics, pre-hypertension, or starting their hypertensive curves. We do a lot of expanded testing. So it's based on the Bale-Donine method. So we do a lot of inflammatory testing in the blood, which is a little different than some of the other traditional tests that are done. And then we coordinate the care with any dentist of record. So, my water. Any of the dentists that we have, even if they're not in our network, we'll still coordinate with care with them because we have patients coming in off the street. All right. So some of the examples of the services that we offer: primary care, obviously, metabolic screening, minor surgery. We do basic GYN exams, so you can kind of read that yourself. But this is your typical primary care practice, is what it is from a standpoint of what services we offer. It's kind of our marketing. So this is a little bit of a look at how we market to the patient population. So we're trying some different imaging. We're trying some different messaging. We don't know quite what's resonating yet, so we're still working through some of these things. But we're pretty proud of the work we did so far. It seems to be resonating well with the patients. And so I want to just talk a little bit about, we've seen about 380 patients, I believe, on the medical side so far. 189. Sorry, 189. We've probably picked up about 35 or 40 cases where the patient would have not been diagnosed with a systemic disease. That both came in from the public, obviously, but we've also had quite a few, about 25 or so from the dental side directly. I want to talk to you a little bit about David. David's a 43-year-old Caucasian male, came in with a molar fracture in his right lower jaw, and he had periodontal disease, 5 to 6 millimeter pockets, a little bit of bone loss, but he had no idea he had periodontal disease. He came in for the fractured tooth. Professional, this was a professional gentleman. So Dr. Sheristani talked to him about getting over to Dr. Waltman or somebody to get his systems checked out, that he could be this is a risk factor for other systems diseases. So we did blood work on him. Turns out he had massively elevated inflammation in his bloodstream. The CIMT came out normal, but a little bit of lipid elevation, and he was definitely pre-diabetic with his A1C. So we've got this guy on a statin. Obviously, we're monitoring his diabetes, got him on a dietary regime. But here's an example of somebody that we believe that we probably saved this guy's life. If he hadn't come in with a fractured tooth, or we certainly have prevented him from having a lifelong problems with his diseases. So we're hopefully catching him early enough, getting him on the right medication regime, and getting him on the right program so that he will live a great, healthy lifestyle, live to be 96 years old. So that's just an example, but that's what we want to do. The goal here is, if we end up having a fantastic medical clinic that's very profitable and successful, and same thing on the dental side, and they're not integrated, for me, that's a loss. For me, that's a loser. I'd much rather see a little less success and have them massively integrated. That's the program. That's our criteria for success, is having the full integration done. All right, thank you very much.
Thanks, Tom. All right, and next is Ken Wright, who's Vice President for Dental Care Services at Kaiser Permanente Northwest.
Can you all hear me? Yes. Good afternoon. Good afternoon. Now, you've heard several speakers refer to the ravages and dangers of postprandial bliss and redistribution of splanchnic blood flow, so I'm going to help you with that. Could you do me a favor? Just stand up for a second. Yes. Okay? Please. I know you've been wanting to do that for a couple of minutes. Whenever I come to these meetings, I learn more from you than I could ever hope to share. And some of the things I learned today were things like random collisions that I hope that you're immediately converting to focused collaboration, very kinetic focused collaboration. We talked about chloroform phrases, those phrases that put your dreams, your innovative ideas to sleep. It's too hard. It's too difficult. It's never been done before. It's not in my silo. You know, how do we address those? You talk about accelerating our trajectory of change, making it happen faster. And you've demonstrated uniquely throughout today that you're doing that. You're developing pathways, algorithms. You're enlarging the narrative for healthcare and collaborative care in this country, and it doesn't get any better than that. So I want you to turn to the person next to you, congratulate them, shake their hands, and say, "You're awesome." And I want you to raise your hands high to the sky and say, "We're awesome." And don't you ever forget that, all right? Wow, it's quite a pleasure, and I guess I can start the slide deck. Okay, no, I just didn't know how I want to start the slide deck. Can you start that for me, or do I need to do that? I've been very fortunate when I joined Kaiser, it was actually 5 years and 10 days ago. I keep track of the days, just in case, right? I spent most of my life in the military in an integrated system where collaborative holistic care was the plan of the day. You know, it was a natural, you had to do that. Your competencies, your ability to progress through the system depended on your ableness in demonstrating that awareness, right? So I'd like to talk today a little bit about how we have developed that over the last 4 decades at Kaiser, the impact it's had on the population that we serve, and how we actualize that in our day-to-day processes, including how we build our practices, our offices. I'd like to share with you a homegrown definition of integrated care. You've heard these terms already. It's holistic, right? It incorporates the fact that, acknowledges the fact that the mouth is a part of the body. It always has been and always will be, right? It's an organizational construct. It's how we approach the life of the patient, who's the center of our universe, by the way. Everything generates around that patient encounter. It's a culture. It's about removing silos, barriers to care, barriers to collaboration. And it's easy to do when you think about it. You know, the headquarters for Nike is homeported in Portland. They have a saying, just do it. Just do it. It's going to be hard. God, I grew up in New York City. I played football at Columbia. So I know what it's like facing barriers, right? How many games did we win at Columbia, guys? I've always believed that we can shape the future. We can change the momentum. One of the first models I saw of integrated care was a depiction like this. What's missing here? Where's the mouth? How long has the mouth been missing? Maybe not in our mindsets, but in our day-to-day interactions with our patients, whether it's our mid-level providers, dental health therapists in Alaska, or whether it's mid-level providers that we leverage in Minnesota and other places. It's time that we eliminate those silos. It starts with addressing interprofessional education, when we train our providers from day one so they feel comfortable, right? So when they graduate from dental school and they're licensed as experts, their learning doesn't stop, that they continue to demonstrate that willingness and ableness to share with their patients and with the environment and the communities the fact that we can provide a difference. Members expect that. We survey our members all the time. I remember one of the surveys, the member said, if you think of your overall wellness, I think they are very much connected. I think it's the way society has brought us up as two separate things. They should be combined. This is coming from the voice of our members. And we use Press Ganey to survey our members all the time, right? It's about identifying algorithms for care, providing the care, and then double-checking with your patients to make sure you're doing the right thing at the right time. So we do that constantly. So some of the limiting factors in your world, these training programs, professional identities, payment systems, delivery systems, are all mitigated against being a collaborative model. But it doesn't always have to be that way. The future is yours. You're the enablers of health. The future is yours. You can make it happen. Why not? You're awesome. It's a natural. We know that there are multiple external forces that are going to force us to do it sooner than later. If not forcing us to do it, it's enabling our ability to do it. It's making it easier for us to do it. It's certainly public awareness, public demand for value, the research community that's been an enabling force in being able to demonstrate at least a causal relationship, association, if not direct causality. And certainly the federal government's becoming involved now. How can we leverage that national awareness, right, to enable us in our cause? At Kaiser, we have an integrated healthcare system. We're able to, like some of you have, we're able to demonstrate the collaborative effort at every level of the healthcare team. We have hospitals, we have a dental group, a medical group, and the health plan side that brings everyone together in a collaborative manner to ensure that the patient's care is being coordinated and fostered over a period of time. It's recognize the fact that the total health equation is incomplete unless you include the mouth. Healthy smiles equal healthy members. That's a part of our DNA. We tell that to the patient. I'm a periodontist. You talk about making patients feel guilty. The periodontists are probably the most active members of the community in terms of making patients, if not guilty, comfortable in their environment, right? So it's a total health focus. As a member of this leadership team, I sit on the Senior Leadership Council. We get involved in obligating resources for the region on a yearly basis. Medical dental integration is one of the top 3 priorities in the region every year. It's not just in how we approach patient care, but all of our facilities, as we construct them in the future, will be integrated, medical and dental in the same building. And I'll demonstrate one of those models at the end of this presentation. We have rigorous peer review to ensure that the dentists are doing it, right? Not only is it a paper review, they're compensated by being able to demonstrate that they're closing care gaps. We are accredited by the American Accreditation Association for Ambulatory Healthcare every year. We're one of the first 3 dental homes in the country. So we have external organizations come in and look at us to make sure we're doing it, providing the care to the members. Dental providers are members of the healthcare team, equally committed to ensuring that the members are always sought first. And this is just one tool that we use. It's called a patient support tool. It's a handout that our hygienists and our dentists provide to our patients when they come in for care. Generally, about 30 to 40% of our patients who come in have some type of health care gap. Excuse me. And because they have access to the medical records, they were able to publish this document for the patient in advance. In this case, the patient was due for diabetes monitoring test, HbA1c, lipid panel, and a kidney function test. And in most cases, we can actually schedule the appointment for the patient before they leave, or at least share with them the fact that this critical diagnostic test is missing and put them in a position where they can schedule that themselves. But the key is to become a partner with the patient in ensuring their health. Typically, we're one of the top 3, there are 35 departments, but we're typically one of the top 3 departments in the region in closing care gaps. One, we see patients a lot more than our primary care providers do. So there's a tremendous opportunity to engage patients in those conversations and then vector them to the care that they rightfully deserve. You've heard the term IT, very expensive and critical component of our system, integrated healthcare record. We were fortunate in that we will be one of the first, and we use Health Connect, Epic Health Connect in our medical system, and Epic developed, and we worked with them over the last 3 years to develop a module called Wisdom, which is fully written on the Epic platform. I started deploying that about a month ago. By the end of the year, all of my clinics will have an completely integrated healthcare record. Remember, we currently have access to the medical records, but physicians don't have access to our dental records, which is Axiom. But at the end of the year, everyone will have access to that. We'll be closing dental care gaps, medical care gaps. We have access to problem lists, medication lists. So if a patient comes to you and says, oh, doc, I've got a toothache. I've been awake for the last 39 days. I need some drugs. And he asked for hydrocodone. And I said, well, you know, you got 135,000 tabs of hydrocodone in the ER last night. I don't think you need any more. Imagine the power of that, right? But I think it's critical in ensuring that we can leverage the primary care provider and dentists as an extender of primary care. This is what it looked like, much as what you're currently experiencing before integrated capability went into place. Paper charts, dental-only practice management system, lots of errors, risk for errors, right? Post-Wisdom, we'll have completely electronic records. Transactional data will be seamless and integrated throughout the region, no matter what clinic you go to in the state, even across Kaiser as we expand into other regions, it'll be completely linked together. Fully supports our regional revenue collection capabilities, which is important for our regional president, by the way. That gives us the resources that we can expand and develop further capabilities. And it also, what's even more important than that, it allows the patient to become intimately engaged by developing an online and mobile capability. I don't know if you're familiar with the KP Medical app, where I can actually schedule my medical appointment online. I can see certain clinical transactions, like my medical record, they'll be able to do the same thing for dental. And I'm down to 1 minute and 32 seconds. So the bottom line is that we view the entire healthcare team as a critical component, managers necessary to ensure that our members who are the center of our university are in the center. All of our behaviors are guided around providing care to those members. Nutritionists, pharmacists, case managers, educators, medical providers, all intimately linked together to ensure that the patients are getting the care that they need. We do that by providing treating medically complex patients. We do oral health clearances for diabetes, for head and neck cancer, cardiac surgery, patients who require medically necessary care. And we have a program where we do outreach to members who are diabetic patients who are overdue for dental exam. So it's a proactive effort to make sure that the members are getting their care in a timely manner. Providing the care at the right time, things we've always done, we were taught from day one in dental school we should feel comfortable doing forever with our eyes closed. I once told one of my students, I taught when I was in the Navy, the residency program at Bethesda, that I can manipulate the tooth surface with my eyes closed, intimately, professionally, and exquisitely. You can do that too. It's recognizing the fact that our primary care teams are used to doing these things. They're great educators. They work together with patients. They understand the entire continuum of care and how important oral health is for that. And we have a unique partnership with our medical providers in Kaiser. We interact together. We don't share food and break bread together. But we do have an annual golf tournament that we participate in together. But we intimately realize that it's an important part of the care that we provide our members. And our CEO, Bernard Tyson, just recently endorsed that by saying that we intend to expand the dental program into all of the Kaiser regions. We're talking about 10 million members, which increases our dental capacity by almost 4 million members. And that's an organizational commitment to make that happen. You've seen some of these articles published in Journal of American Dental Association, the impact on oral health, diabetic population who receive dental care, impact on hospital stays. They tend to smoke less, spend less time in the hospital when they're inpatients, fewer visits to the hospital, and they're generally healthier. What I did, and just promise you in about 5 seconds, one of the things I thought was missing was the fact that we leveraged surrogate measures of health to demonstrate the fact that we're making a difference. In the military, for those of you who have worn the cloth of our nation, you realize they use classification system to track how healthy the members are for deployment. So we modified that to an oral health system, where a system is segregated into one of 4 areas. Class 1 means that they're completely healthy. They could go out to the community, go camping, go on a safari for a year without seeing a dentist. A Class 2 patient who's under maintenance, maybe perio maintenance, only requires a simple pro-few cleaning, something like that. That acute patient, or OH3 is a classification of systems who have not, if they're not seen immediately, or within the next few months, they're probably going to end up in the emergency room. Those are the patients we target. In the military, I placed that on every commanding general's desktop so that he had access to, which meant that patients never failed their dental appointments, because he wanted to make sure that that unit was healthy when they were ready for deployment. As I mentioned earlier, the members who have medical and dental, and 90% of our dental members also have medical, Kaiser Medical. They weigh less, they smoke less, visit the hospital emergency room department less, have a higher adherence to 7 of 11 HEDIS measures. And we've been able to, and even though actuaries will tell you that some of our best friends and sometimes our most, well, I won't say worst enemies, but they make it difficult for us to tell the story. You know what I mean? To actuaries, the truth is never the truth until 12 years later when they can statistically prove that it worked 10 years before. But we've demonstrated that there's a correlation between chronic medical condition members with dental care and an $11 million annual reduction in future medical costs. And that's working with our actuarial team as well with the Center for Health Research, which is a critical partner in our region who work with us. So I apologize for running fast and so fast. This is the next generation. I'm opening up this clinic in about 3 months. It'll include a low level of acuity, medical capability. A nurse practitioner will be there. She'll be able to close medical clear gaps at the same time facilitating care for our patients. We're leveraging the new RAD design with Kaiser. There'll be a telemedicine room. There's something called a Thrive Bar, when the patient in the waiting room can sit down and have a conversation with a nurse or with a dentist about their health care. That's the future. That's you. You can make that happen faster than I do. That I can. So thank you for your attention. lots of opportunities to leverage the enabling ability of working together in a primary care environment as part of a primary care team. Lots of challenges we've talked about. They're not impossible to overcome. Kaiser is not perfect. We have silos too. But the key to remember is that medical and dental integration is the future, and we're better together. So, thank you.
Well, thanks very much, Ken. That was great. The whole issue, could you just pass it over? The whole issue of the EHR just becomes so critical to all of this, and so we're all going to follow, Ken, what you folks are doing at Kaiser. I think that in the work that we've been doing, the example of what happened with the Ebola patient in Dallas, Texas, really tells a story in a very dramatic way. That what the physicians were looking only at the MD record, part of the record, weren't looking at the nursing notes, which all said, okay, he's come over, he had been working with embalming patients and so on and so forth, but the physicians never looked at the nursing notes. So an example of how breakdowns can occur, but if we can get once dentistry gets into the EHR, it's going to, hopefully, our access to all that other information is going to help tremendously, and then hopefully it'll go back the other way. We got lots of opportunity for questions. Dr. Alfano.
So,
there's a mic coming here, and if you could remind us who you are.
Mike Alfano, retired.
Retired.
Question for Dr. Wright. It was back on, I think it was slide 117, but I didn't really get a good look because it was moving pretty quickly. But I believe at the bottom of the slide, you underscored savings based on diabetics getting dental care per member per month. I saw one part of it was $101.
$121.
Okay, there was another one that was higher, okay, 123, is that? Okay, so, and I had heard on a second-hand basis of this kind of information from...
And Aetna did similar studies looking at a population a couple of years ago.
Yes, and I'm aware of that. My question is, how do we get this information that is held by the private sector into the hands of the governmental programs? I'm speaking specifically about Medicare and Medicaid. Because I now had 2 visits with the CMS specifically to focus on sort of teasing their interest to understand what's happening in the private sector, that there's a great deal of money to be saved if dental care is offered, particularly across a certain set of inflammatory diseases, as you showed earlier. And the CMS is very interested. They see us when we ask for a meeting, but so far we haven't broken through with a request for proposals from CMMI to actually pull this data out of the federal system. I think that's coming. My question is, what can we do to now tease the private sector to be more forthcoming with the data?
And sharing the data.
Yeah, I mean, we've seen the retrospective studies that have come out. Margie Jeffcoat published some, the Columbia Group has published others. But they get critiqued as retrospective studies, and therefore, in a large measure, they're discounted by scientists in the federal government. But we now know that you're doing these things prospectively, that you see the data still delivering savings on the health side. How can we jumpstart the federal government to begin to do the same thing with Medicare and Medicaid?
Well, my great-grandmother once told me that good things may come to those who wait, but only things left by those who hustle. I think if we sit back and wait for the federal government to come to us, to respond to our inquiries, to provide information, it's not going to happen, or it's going to be too infrequently. Those short, choppy steps that are not really adequate. It's going to take a great giant leap, and you can take that leap by becoming proactive, by being aggressive. You know, Marines have a term they use, agile, being agile, mobile, and hostile. You almost have to do it with hostile intent. You participate in multiple forums like the Harvard Initiative in integrating health and medicine. We had an opportunity to participate at the ADA conference last year, the MSDA conference, where you bring all of these national thought leaders together. You share the information, you get their cards, and you call them. and you continue to call them. Don't go away. I mean, you know.
We actually are doing that.
Okay.
And I'm trying to move even
Faster than that.
following your lead. And one thing that could really move it quickly is if the federal government was able to understand
Sure.
what is now known by the dental insurance industry.
Well, why not, we could talk about this off. Why not come together collaboratively then and generate a perspective? I know that Qualis has done a lot of work with that, DentaQuest and other groups, and aggregating the data across systems of people who are demonstrating the wellness that can be associated with oral health as an enabling capability. It might take us coming together in a subgroup, a small group, and generating a plan of action to make that happen. And certainly I think everyone in this room is willing to do that with you. But certainly at Kaiser, I'm willing to share all of our data sets. Right. You can come and visit our clinics anytime, watch our providers as they practice and interact with our medical colleagues, both nurses, social workers, physicians, you name it, pharmacists, they all work together collaboratively. So I think giving people an option to come in and experience it, even the federal government, and I've invited them too. Bernard Tyson gets a lot of invitations to the White House to talk to them about healthcare in this country. Hopefully next year they'll be talking about oral health too as part of the agenda.
Introduce yourself, please.
Hi, my name is Conrado Barza. I'm with the Center for Oral Health in California. And I have a question for Dr. Wright, and it's not a criticism, it's a genuine question. Why did it take so long for Kaiser Permanente to...
I criticize that too, but...
It's not a criticism, really. I really want to know what took so long for Kaiser to integrate the services when they already had the services on site.
Right. Well, first of all, the Northwest is the only one that has a dental program today. It was started as a pilot program in 1974 to see whether or not it would work. And it worked, and it worked, and it worked. But there was a tyranny of the immediate. It was multiple regions, the capital involved, cost structure, and starting up a new program. It wasn't a core competency for Kaiser overall as it was for us in the Northwest and for some of you. That dialogue, that narrative has changed, as I mentioned before. And it came from a lot of participation. It was one of my goals when I came aboard 5 years ago was to change that dialogue and that narrative, and it's changed. You know, we're scheduled to provide a 225-page business plan on Monday to the board of directors to talk about an expanded regional program, and that's what it's all about. But it took time, even at Kaiser.
Even at Kaiser. Next over here. Who are you?
My name is Fabiola Malord. I'm a clinical instructor here at NYU for the College of Dentistry, and I'm also a private practitioner. I couldn't agree more with what Dr. Morsi said about what we perceive as important. Our consumers, known as patients, may not perceive as important. And I think we're in this conference, with this two-day conference, I think we're preaching to the choir. I think a lot of us, if not all of us, really do understand what we're trying to achieve about interdisciplinary collaboration. But do our patients understand that? And how do we drive our patients into the clinical settings that we practice in? Because that's the problem there. They have so many other issues that they are dealing with that going to the physician and going to the dentist only becomes important if there's a problem. And we're talking about prevention and collaboration and everything else, but my question is more about changing the mindset of the patient so that we have some buy-in from the patient so that they understand how important it is. Because the other day I had one patient come in, and I can't remember which insurance company or where the payer source was from. A child came in, I need a school note or whatever note sign, and it had to be stamped by multiple practitioners, and there was an incentive for that form to be turned in. Yeah. So they were getting paid to actually visit different practitioners. I guess that's one model or one way to address it. So my question is, I completely understand, I buy in and I believe in everything that was said today. You're preaching to the choir. Well, I think how do we change the mindset of the community?
So one thing I think is what Dr. Morsi was talking about, the issues faced by people in the community. And that's why, at least what we're trying to do is expand the work that we're doing. And now, for example, we're opening up to further, to additional organizations that are coming in, like the American Institute of Architects, like the engineering schools, like schools of business, law schools, to try to broaden the circle so that we can deal with the social, behavioral issues, those other determinants of health, and to try to get, because that's where we have to go, what you described so well.
Well, and I think getting that message across is one thing community health workers are very adept at. You know, they're in and of the community, their peers, they're forget about culturally competent, they're of the culture. And if there's a language issue, they're typically, so they can convey that. Visiting nurses as well, you know, they have that training, they're in the community. And these are things I think we can do is piggyback on existing. We don't need to recreate the wheel. This was a wonderful program. We trained community health workers, gave them oral health training. But there's other services that are already being provided out in the home, around the community. Let's piggyback on existing infrastructure, give them the oral health information they need, and extend what we do. I think it requires a little humility on our part that, you know, maybe we can't do it all. We need to now have others participate with us to extend our reach and meet those goals.
You know, it's interesting, just want to comment on this. This is not confined to all just this particular socioeconomic group of folks. You know, we deal with upper middle income families primarily. We have a heck of a time getting them to do what they're supposed to do as well. So this is a ubiquitous problem. And I mentioned the marketing there. That's one of the things that we're trying to understand is how do I activate a 35 to 55-year-old male or a 40 to 55-year-old female to come into our medical clinic or our dental clinic? How do I motivate them to do that? How do I activate them to do that? And we're trying some marketing messaging. We're trying a soft approach, a hard approach. But this is ubiquitous. We diagnose roughly about 58% of our new patients have been diagnosed with some form of periodontal disease. We only get about 52 of them to do the treatment. So, I mean, the problem is universal.
All right, over here, and then Dr. John.
So I just have Mayumi Wilgrow, University of Washington. I have one comment, one question. I think the issue about in our experience, the patients are asking for this. They're asking for us to communicate more effectively together so that they can have some sense of coordinated care. And I think we need to be really careful about starting to sound like we are putting the burden on the patient to understand how important it is, and so therefore they need to come to us. So I just want to sort of caution about how we talk about the patient. My question, though, one of the other hats I wear is as a school nurse, and I believe that the school nurse is essentially the glue to care coordination and collaborative practice out in the community. But the problem is that they have to facilitate collaboration amongst different systems. So it's one thing to be in one healthcare system, Kaiser, NeighborCare, where the communication is a little, it's not easier, but there's infrastructure there. So what are your thoughts on situations when you're working with multiple systems of care, and how do we facilitate collaborative practice across those systems?
Well, I've got an answer. I mean, I have an opinion. It's not necessarily the answer. I mean, I think what we're seeing is an expansion of the primary care team taking on more and more responsibility in multiple layers. And I think the challenge that we see when community health workers have to coordinate across multiple delivery systems, which is exactly what you're talking about, because it amplifies the fragmentation that everybody's dealing with. And I think the biggest challenge we have in primary care, at least, is everything is fragmented. The payers are fragmented, the information is fragmented, and the more we can integrate into a single system where there's a single point of contact and start to, I think Kaiser has a tremendous advantage in this because they can hire their own community health workers. And I think that what I see happening And I really like the fact that you brought up asthma as an example, because in Puget Sound we've had a long history now of community health worker programs in the community health centers, with community health workers going out into communities, and I've accompanied them on some of their visits, and it's fascinating to watch. But I think that it may not be at the team level, but it's certainly at the clinic and delivery system level. So everybody's using the same information system, everybody's looking at the same chart, the message is aligned, and then the community health workers can interpret all of the really great observations you made about that we prioritize things differently than our patients may, because we can't see the world they live in. And so I think it's an integrative process.
If you could bring the mic up here. While we're bringing the mic up here.
It's there.
Okay, and then to Dr. Donna.
Okay, thanks. Mary Lee Conicella, Aetna. My question is for Tom. So Aetna and Pacific Dental have talked about this for a while now, this concept of dentists doing more things around health. And in your presentation, you mentioned that you were thinking about dentists doing finger sticks for A1C or lipids or C-reactive protein, and that credentialing issues and certain state regulations prevented some of that. And so we found through our discussions that certain states, for example, their state dental board is silent or might even say that it's out of scope of practice for a dentist to do those things. So I feel like you guys have really hit on something, having this practice where there's a medical, a healthcare practice, and a dental practice co-located with one another. And maybe is that the answer to dentists or a dental practice doing those sorts of tests if they're co-located in the same practice with their medical counterparts, and maybe those services can be billed under the medical
someone
side?
mentioned the family practice gentleman who was up here from Washington used the word absurd, I believe. And I find the absurdity of dentists, not, a pharmacist or other healthcare professionals can do these things. So it really is, one of the things as a group we can do together is continue to push on these things. It's ridiculous that a pharmacist can do a finger stick or give a flu vaccination even, right? But yet a dentist cannot. But they can perform oral surgery. So, this is like the most bizarre rabbit hole I've ever dropped down. And I do think it would go a long way, because everybody's talked about how frequent the patients see the dentist versus the clinician, the medical clinician. And, if we could have dentists on a regular basis, and they don't have to do this finger stick, the DA can do it and they can interpret the results. They're not diagnosing from it, but, if your A1C on a finger stick is, 6.0 or whatever, it's time to go, you got to get your buns over to the doc and see if you're diabetic, right? Or blood pressure's out of control, or whatever these things are, or you have an inflammatory response in your bloodstream, and you've got elevated cholesterol, and you're not on any kind of medications, right? Well, you're gonna have a stroke or heart attack. So I don't know why we can't do that. And we are going to try where we can. We think we can do it in Arizona, so that's where we'd like to do the pilot. But
Bruce.
So first, the suggestion, Ken. Why doesn't Kaiser open a dental school with its medical school?
Well, that's next on my agenda.
Huh? Hal could be the dean. He has experience in that.
Right down the block, right?
Right down the block. To your question, I think the inability or whatever the barrier is that prevents dentists from doing finger sticks is also the thing that drives dentists towards using saliva, which I think is artificial and not necessary. In any case, I would ask you, David, and you, Ken, why Epic? I've been through 20 hours of Epic training. I use Epic at the MGH. It is the most non-intuitive. It took me 7 minutes to do a biopsy of the tongue a couple of weeks ago and 40 minutes to fill out the path form. Why?
Well, the answer that I would offer for that is because we are the tail on the dog, and the dog has Epic, and so if we want to truly integrate medical and dental care and health partners, and I believe that would be the case at Kaiser as well, you've got to have that common platform, and both Kaiser Dental and Health Partners Dental worked with the Epic folks to make their new wisdom module for dental much more user-friendly and much more easier to use.
All right.
Epic's one woman.
Hey, I'm Casey Hine from the University of Manitoba. You know, if we really think about medical dental collaboration, just teaching non-dental healthcare providers about oral health is just one part of this. The part that's never really discussed is teaching oral healthcare providers how to look beyond the tonsils. And in the same very report from the American Association of Medical Colleges, which was published, over 10 years ago, that mandated curriculum reform in this area, and that very same report, it also recommended that as we're training dentists and dental hygienists, that they need to learn more about overall systemic health. There has, to my knowledge, there has been very, very little movement in that. And to Mary Lee, to your point, you know, why? Why is that? And if we look at, Dr. Wright, using oral health care providers as primary care extenders, that's just not going to happen until there's some huge effort in that regard. So we've got a lot of work to do in dentistry, and I don't know where those barriers are. But
Judy, just I was asked to give a presentation at the Association of American Medical Colleges. There's 600 people in the room. And the title of my talk was the oral cavity, that space between the lips and the tonsils that no physician ever looks at. Yeah, go ahead.
Bingo, because I want to say back to everybody who's talking about the importance of in expanding the overall health lens of the dental profession, which I totally support. But let's not forget what Jeff was talking about and the framework that he presented, because if we're going to work collaboratively, we need to put pressure on the medical side through all of its physician, nurse practitioner, midwife, physician assistant, nurses, medical assistant, providers to be part of the game. Because if they're not on board, you know, this will be nice to do finger sticks and stuff and have an integrated record, but it won't come to fruition. So we really need to find a way to put pressure on both sides of the healthcare equation so that we have real collaborative practice.
All right.
I think positive.
Dr. Slavkin, if we can. And then.
You accept.
Yeah. Yes. Thank you very much. I was sort of ruminating after your presentations, which were very provocative, and thinking back. It must have been, I wasn't alive, in the 19th century, in New York, very, very wealthy people, highly successful in the private sector, non-government people, decided that public libraries were an important thing, and they should be an entitlement to anyone who wants access to a book, and not a crummy book, just a regular good book in a library. And so today, a long time later, we've got public libraries everywhere. Everyone in this room has utilized public libraries. We consider it an entitlement, which is a word we tend not to use in our country. But thinking of who those patients are that are recalcitrant, who even if it's free, don't follow up, don't keep appointments, all of that, we're skipping prenatal care, early childhood development, K-12. This country has the finest universities in the world, and at the same time, mediocre K-12 education in big cities. There lies something that's not about a patient, it's about our society and its future. What do you think?
Right. Absolutely, and it's a huge missed opportunity. Yeah, absolutely. For example, a 3-year-old child will come into our clinic today with severe dental decay. The only way to treat this child is in the operating room, for example. We're booking into February. Okay? And this is not just us, this is throughout the country. So we ask them, hey, you know, have their vaccines, their general health? He always sees the pediatrician all the time. where has that pediatrician been? Where has that nurse practitioner been? The typical 3-year-old has seen a primary care provider 12 times for well child visits and probably more for other things. So those are missed opportunities. If we can train our primary care practitioners to do that oral health exam, then hopefully we won't have this long line of 3-4-year-olds waiting for the OR at Bellevue. And real quick on the school-based health, that is another huge opportunity. Here at NYU, we're in over 100 Head Start and schools, but we're the exception. Using the community school model, many of you who are in urban areas are familiar with this, using the school facility as a community center for health, education, training is a wonderful idea, and I think that's something we can really capitalize on more.
One last question, Mark. Speak loudly.
Okay. I just want to say, early in the AIDS epidemic, we knew that the oral cavity was a prodromal for some of the symptoms of HIV/AIDS. We're now going to have several hundred American women in Puerto Rico who will deliver babies with microcephaly. And there's an urgency in that situation because this fall we'll have several hundred babies with microcephaly that we really need to have an interprofessional care team to address. And it might not just be in Puerto Rico, but next spring we'll be in Miami. So we've got a situation already with emerging infectious diseases that there is a role for the oral care providers in that mix and how to better integrate them. And I think it's one of the compelling things that we need to begin to think about.
And if you can get Congress to fund it?
Well, Congress is another problem.
Well, thank you all. Wonderful panel. Great job. Thank you. We have a coffee break, and we'll be back here at 2:45. Thank you. Thank you. Thank you. Thank you. Thank you.